to have all of you with us today. I'm very excited about our panel today. They're actually all returning guests, and I enjoy it every time I have them come on. I've got a great panel. So at the very top of your screen, you're going to see right to let's see my right, your let's see my left, your right. I have Miss Amy Brown. She is the chief nursing officer at Sparrow Hospital, located in Lansing, Michigan. Welcome to the show.
Thank you. Thanks for having me.
So glad to have you. And then also we have former CNO, but doing a lot of great work with the American Nurse Association, national speaker, all over. I'm seeing you all over the place, Katie. Welcome to the show, Dr. Katie Boston Leary.
Good afternoon. Thanks for having me, Rollis. It's always a pleasure to be on your show.
Absolutely. So, I really want to talk about what's kind of top of mind right now. We're starting to see some of the cases come down, which is great. The hospitalizations come down, which is wonderful news. Want to hear whatever you're hearing with your. I know you both have your ears to the ground in different areas. With you, Katie, with the American Nurses Association, and then of course with you, Amy, on the ground, leading a 500 bed hospital on the nursing side. I want to hear what's top of mind for you guys. Is that something that's still a big part of the conversation? And I also want to celebrate some recent successes. And those who are watching in the comments, let us know if you've had any recent successes, anything that's working for you, and what's top of mind for you. We want to make this very interactive between all of us. So, Amy, would you like to get us started? And then we'll move over to Dr. Katie Boston Leary. How about that?
Sure, sounds good. So, like you said, Rollins, there's a lot of. It's been a long 2 years throughout the pandemic, and we've had several different waves of high volumes of COVID patients. We experienced a significant wave, I would say, in December, and it's probably was one of the lowest points of my whole career, just because I think it was almost a year after the vaccine, and I was really thinking that we wouldn't be back in that place. Our hospital experienced the most deaths we have ever experienced throughout the pandemic in December and January. They were mostly 80% were unvaccinated patients, and some of them were very, very young. So it took a really hard toll on my staff. So we're dealing with a lot of burnout, exhaustion. We struggled with staffing, and then a lot of our caregivers started testing positive again for COVID. So
Oh,
it was just
yeah.
it was very, very difficult. On a good news, our cases are coming down. They've been trending down. It's been slow, but it's been a down trend every week, which is great. And then we also were we put in for help from the federal government, and we welcomed 24 members of the Army on Saturday. We had a welcome parade for them. It brought with them 14 nurses from the Army, and they started their clinical rotation, and they started orientation on Sunday. And so it's just been a tremendous morale boost for all of us to have the additional help, and just the positive energy that they've brought to our organization.
That's awesome. Okay, what about you, Dr. Boston Leary? What's going on your side?
Yeah, well, Amy, this is just I just really am thankful for your leadership during this time, and that's what we've been trying to do at ANA. In addition to hearing what's happening on the front lines, but also lifting up our nurses and our nurse leaders, and this Herculean task and effort that's been never ending. Has taken a toll. So I hear you when you say lowest point of your career, because it seemed like it was at a point where we started to get some hope, and then this variant came along, and it was also an indication that even though we felt that we were done with COVID wasn't done with us. So, but Amy's story is very similar to what we've been hearing. A lot of nurses and nurse leaders were feeling betrayed in a lot of ways, for particularly with the public doing their own part to end this pandemic and that not panning out. We've heard about workplace violence being a major issue, staffing being an issue, compensation being an issue. So those are the top things that we've been hearing from our nurses and nurse leaders, and I think the fatigue that everyone's feeling right now, they're on the front lines, and feelings of hopelessness. We hope that that will lift and lift permanently, because we've been at this crisis for too long. So I feel for her. I feel for all the nurse leaders out there. And what we try to do is listen and provide some tools and connect people with best practices to help navigate through this crisis. But it really does lie on in the laps of the leaders and the teams that take care of patients. We've also heard about the stories with the federal response and the military jumping in to add support. So those have been nice, uplifting stories as well. So Rawless, unfortunately, this we just hope that we don't go through another cycle like this again, because I don't know what else it will do to nurses in the nursing profession, if and all healthcare providers and professionals, if we were to see another wave like this. Uh-oh, can't hear you.
I wanted to check in with my audience and see if they can you hear me now.
Yep.
Yes.
Yeah, just wanted to make sure that they're also engaged in what you're saying, if they appreciate the efforts, and of course they do. Awesome. Well, thank you for what you've done. I know it's taken a, it's not like just any job where you can just clock in, clock out. I mean, this is one of those things where like a lot of your life is put into this, and we know that you have to have a life outside of work, obviously, but it does take a toll, and so we appreciate the fact that you've been in this for as long as you have, and still helping and inspiring others. So thank you for what you're doing. Um, Now, there was something I did hear, Amy. We were just speaking a little bit ago about one of the recent things that you guys were excited about, which was having some of the military folks join. And tell me how that affected your staff. Kind of what maybe some of those stories you saw to help show the re-engagement on your staff.
Yeah, so on the day that they came, they were in their army fatigues, and so I think it just that the uniform just kind of brings that. It's just a different feeling to see 24 people in their military outfit, and I think it just it they saw the number of people that were there to really kind of to help them on the front line. And I think that they just felt so proud to have them here. The morning that they were arrived, we had a group of people that were in the lobby, and when they came through, multiple people were clapping and thanking them. And I looked over at one of our PCTs, which is a patient care tech, and she had tears streaming down her face, and she just said, we just need this so badly. And it's only 14 nurses. So it's not like it's going to solve our staffing crisis. I truly think it's them feeling like there's hope. And that to me, that I really resonated with that.
That's awesome. Give us an idea of the scope of your organization. Roughly how many are employed there, and roughly how many nurses do you have, so they can put some perspective on those 14 nurses you're talking about that
Sure.
were added.
So we have over 2,300 registered nurses. However, we have multiple different, like we have a cancer center, we have different clinics. So the registered nurses work in a lot of different areas. Where we're obviously struggling the most is not unlike other hospitals. It's our inpatient adult units. So we have at least 14 inpatient adult units, and six of those converted over to COVID. So they were oncology, orthopedics, um, neuro, and they all became COVID units where they were all COVID patients. And so definitely they really had to shift in the patient that they were taking care of and learn and just be flexible. And so 23, out of 2,300 nurses, 14, like I said, isn't a lot, but it's on night shift. They're primarily just on the inpatient adult. And that is truly where the amount of openings that we have right now is on the night shift, and it's in those inpatient adult units. We have over 210 open RN positions. We have over 100 patient care tech openings right now. Um, so we're struggling with regards to finding nurses as they continue to leave either healthcare, which is very troublesome to think about, or they're leaving to go to an agency.
Yeah, those well, lots to unpack there. Okay, so now that's helping you on a local level,
Yep.
and I got two things from this. One is that it didn't take a whole lot to really give some encouragement to those nurses, because when you think about the difference between 14 versus 2300, just seeing those folks come in saying, okay, we've got some extra help, made them feel better. So a lesson I get from that is sometimes it may not take a whole lot, but just some level of support during this time can make a difference. Is that a fair
Yeah.
assessment?
Absolutely. And I think that, to your point, Rallis, that those little things can't be, you can't underestimate those little things. For Valentine's Day, we're doing this Share the Love campaign. And so we put uh, Valentine bags on all the units, and we asked our community to send in Valentine cards. And the outpouring of support from the community that have been sending in these handmade Valentine cards is just tremendous. And so we're putting those out on the units, and it just brings a lot of a smile to someone. Those little moments are truly kind of what's, I think, helping us get through this healthcare crisis.
Appreciate that. Now, okay, now I know you've got a wider scope, Dr. Boston Leary. What does from your purview when you're looking at it from the ANA standpoint, what you're seeing is what she's saying resonating with things on a national level?
Yeah, I think every bit of support is appreciated and valued. In some cases, it's the small things, and then there are also the large things that needs to happen to support our workforce. Which is why at ANA we sent a letter to the Health and Human Services Division that to declare the nurse staffing issue is a crisis. It's not to say that we're just finding out that there's a shortage. It's just that when you name it a crisis, other efforts and resources mobilize. So there is a need for all types of support, big and small. But it also depends on your vantage point, right? But there are some similarities. So for a nurse working her shift, as she's going in today at 7 p.m. to work her 7 p.m. to 7 a.m. shift, the first thing that she's thinking about is, do how what is my staff? What is my workload going to look like, right? How many people are going to be on my shift? Am I going to have the support in terms of the other nurses so I feel as if I'm practicing safely? And then they think about, okay, now that if I do have all my nurses, what about the support services like respiratory, like pharmacy, supplies, uh, and going back to bedside care, also CNAs or PCTs. So there are the in the moment needs that nurses are looking for that we're hearing. But they're the broader needs that leaders are also looking or searching for to address all these holes that they have in staffing. But what Amy described with having 200 plus vacancies, it's unfortunately the pattern and the trend around the country that we're hearing. Everyone has hundreds of vacancies of nurses, and how are they going to get filled? Make no mistake, even though hospitalizations are decreasing, what about all these holes in staffing? How are they going to get filled? So that is the biggest challenge, and that's where we are trying to make sure we leverage the appropriate resources so that we can get those positions filled with a all whole in government response and also a big business response as well, because a nurse staffing crisis is a public health issue, and we need to get our healthcare consumers to understand that, because any one of us could have needs to as far as healthcare at any point. It's not planned in most cases. Any one of us can end up in the emergency room at any point for any reason. We see our physicians on the ambulatory side, or our providers in terms of advanced practitioners. So it's important, and everyone needs to pay attention and understand that we all have a role to play to understand not only how we can soften the blow with providing support for nurses, similar to what Amy described, but also using our advocacy muscle and getting resources to mobilize so that a lot of the larger resource pools that could be mobilized are used for us to address this crisis.
Awesome. Yeah, that's great.
And
That's great feedback. Go
I
ahead.
would
Go ahead, Amy.
agree. I would agree with you, Katie. I think that it's going to be essential for really for our, when I say organizations, ANA, and hospitals, American Hospital Association, to really work closely together, because we're all have the concern over the profession of nursing,
Yeah.
and it impacts our communities, because at my hospital we've had to close beds.
Hmm.
And so what happens when you close beds is, we hold people in the emergency department, which is dangerous.
Yeah.
We delay surgeries, which doesn't help our community get the care that they need. So, to your point, it is a public health crisis, and we really do need assistance from our, not only our local elected officials, but also, on a bigger federal elected officials as well.
Absolutely.
So what? Okay, so just curious on this. So what's the resources are do you feel actually needed? Because one of the things I looked at a while ago is that there's a little. Last time I checked, this is about maybe about a year old data. There are over 4 million nurses that were licensed. Okay, and there's about three. There was about a little under 3 million that were working, according to the Bureau of Labor Statistics. And even if I added in an extra few 100,000 that turned into nurse practitioners, that still leaves me with several 100,000 that I guess maybe are semi-retired, left nursing. I mean, a number. I guess people keep licenses for a long period of time.
Yeah.
Maybe you can give me some feedback on that, and then let's talk about resources that would be needed to help get us back to where we need to be.
So Rawls, I mean, one of the things, just to point out, is that Katie and I are both part of that list,
Hmm.
right? So, and we're not at the bedside.
Hmm.
So while our roles are both very important, um, there's several roles that are part of that overall licensure number that
Okay.
aren't taking direct care of patients. And to your point, I know several people who keep their license well into their 70s who aren't practicing. They're still contributing to the nursing profession, by doing
Okay.
lots of other things, but they're not going to be working on a night shift on an inpatient adult unit. So
Yeah.
you,
Mm.
Yeah, and then on top of that, you find the places where care is needed the most, right? Where the demand is high is in the acute care setting. And that's where we're seeing an exodus of top talent and competency, particularly with certain specialties like critical care, behavioral health, ED. And even prior to the pandemic, when I was a CNO, I would have some vacancies that would run for over a year to two, not having anyone to fill that position. And that's part of the challenge, and I think that's the change that needs to happen in terms of how vacancies have been managed over the years in nursing, because Amy mentioned closing beds. When you have a flex budget, you are forced to budget to the average beds that you run, right? But if you have a 20 bed unit and your average census is maybe 12, that's all you're going to get budgeted for. And then you hear your CFO says, "Well, if you go over, just staff it." Well, where's that nurse going to come from? So a lot of cases you don't have a replacement factor to make up for when you need to have someone cover for those additional beds over the average daily census. And usually the average daily census is also counted at midnight, so you miss some other occupancy numbers. So that's where it becomes this tail chasing exercise to convince your finance folks that, yes, even though my average daily census is 12 and I have 20 physical beds, I know by 5 o'clock every day, I all my beds are full. So I need a strategy to be able to flex up, and you have to trust that I'll flex down if I need to. So there is a need to look at staffing differently, because what has been the case is put us here where we are, because it's really has been a numbers game for over the years that I've been a leader in nursing to manage staffing. And yes, you do get to cover if you have the census, but if you have the patient shows up before your nurses show up to cover that additional bed. So what are you going to do? And in a lot of cases, your nurse can give you 2 weeks notice that she's leaving, but it takes over a year to backfill that position. So there has to be some creative thinking and new thinking around how to manage staffing nursing to cover the beds that they have.
Okay, now you brought up another point. This. I've noticed this with a lot of hospitals. Okay, I'm just asking questions. You guys are. This is very enlightening. Thank you. All right. So everything has been based off of replacement, right? It's been based off. Okay, a nurse leaves, then we recruit. Nurse leaves, then we recruit. I've talked to administrators before and asked them, if you know so many nurses are going to leave,
Yeah.
why don't you just go ahead and, because history, I mean, the numbers don't lie. You look at the years of history. Why don't we go ahead and staff up a certain amount that we know we're probably going to need at some point throughout the year, regardless of how many open positions there are at the moment? Because I've actually seen several times when nurses apply for a job and the nurse manager says, yeah, we don't have any spots right now. Sorry. And I
So,
know that manager is going to need somebody in about a month from now.
Yeah.
so Rollis, my organization has been very, very trusting in our decisions of hiring, and we last year in May and June we hired actually in that part of the pandemic. You know, some people were laying off people because their census has dropped. We didn't lay off anyone. In fact, we got the support to hire over 100 nurses between May and June. We didn't even have that many positions open at the time. But to your point, we knew that we were going to have turnover, and I'm so thankful that we had the support to do that, because I can't imagine where we would have been in the fall had we not done that. And we have a lot of internal churn in our organization, because the specialty units typically don't have as much churn, like our neonatal intensive care unit, our OR, labor and delivery. And so a lot of the nurses come from those areas to go to fill the. So med surge is almost like a revolving door. It feels like, because they get in the hospital that way. But I agree with you. I think that you have to be forward thinking. The problem that we're in now is that we don't have that luxury right now. I if I'm down 200 in order to get on top of leaves and absences, now I'm going to have to hire 300. That to me is just that's the part where it feels a little daunting.
Yes, yes, absolutely. Okay, I want to get your thoughts on this, Katie. What do you think on this?
So I think this is where, and Amy is in a unique position because she has a team that listens to her and provides her what she needs. But that is not typical in a lot of cases, right? And you do find this exercise that you're left with chasing your tail all the time with trying to make the case for why you need to hire over the trends that you've probably had over the years, and based on your expertise, what you think you're going to need. For example, heading into flu season, starting in December, if we know that we're going to have a high census, COVID aside, then how about you give me some replacement factor FTE so I can cover the spread for the additional help that I'm going to need? Because again, even though on paper I'll be covered if my census goes up and I have more nurses to work. Yes, it'll flex up to the beds that you actually have occupied, patients have occupied for that time. But the key thing is, where is that nurse going to come from? So that's why a number of organizations are looking at float pools. As far as where we are with closing these huge gaps, where a lot of nurses have moved to travel nursing, that is going to be the biggest challenge to figure out how to pull them back into organizations. Because what has held nurses back from exploring travel nursing, and I did that for a while too, because I knew that I didn't want to have a lot of debt hanging over me. So for a period of time, during my years as an OR nurse, I did a lot of travel nursing. And I did it locally, similar to what we're seeing now. But then you didn't get benefits if you were a travel nurse, right? You didn't get vacation days. You didn't get benefits like health and life insurance. Now travel agencies are offering all of that.
Hmm.
So that is a game changer. And then the other thing, the other deterrent for you to travel full time is stable work, right? Because you can have an assignment for 13 weeks, but you don't know whether you get extended and when your next assignment is going to come and whether you're going to be in a place that you like to be in geographically. Now all bets are off, right? You can travel, you can stay home, you don't have to go out of town, and you just get to make more money doing the same thing that you were doing when you were working full time. So that is the biggest challenge, is how do you pull these nurses back into organizations and
Mm.
create a situation that they'll an environment that they'll want to be a part of, notwithstanding the compensation. And that's the elephant in the room too. Like, how do we compete with what they're earning as travel nurses? And
Hmm.
that's a tough one, because our labor rates per hour for nurses are pretty, they're low. They're not what they need to be. And nurses have seen the benefit of doubling their salary just doing the same thing, and having some autonomy as well, right? Because they can decide, I work for 13 weeks and take a month off, or take 2 months off. You don't get to do that when you're on staff. So this is where the creativity and innovation has to come for a lot of nurse leaders like me, and like Amy, where we have to think about and talk to these nurses to find out what we can set up for them to make them want to come back.
Yeah, yeah. Because okay, so I've talked to several about this, and you mentioned a lot of like key points. It's a lifestyle decision for some of them because they're looking to drive down their debt. You mentioned I've heard that several times.
Yeah.
In addition to what you just said, or to confirm what you just said, and I've also heard having that time off because when you're on staff, there's like a guilt there if you want to leave, right? If you want to like take a week off, whatever the case is, this is what nurses have told me. Say, well, I feel guilty because I don't want to. I know Susie or Jim or whoever it is that's on their team. I don't want to let them down like that. I know they're working hard. We're already understaffed, and I don't feel right just leaving, for vacation. So they just end up leaving, period, and then going to do something else so they don't have that guilt feeling. Um, that's another one too. Like even if they have the time off, right? Even if they have PTO or whatever available, sometimes there's like that team guilt of taking time off. And I don't know. I don't have an answer for it. It's just something I was just putting out there. I don't know if you guys have heard this, but I've heard this from more than one nurse, several actually.
Yeah, and if I may, that's part of it. But the other part of that too is, historically we've made it a not so good thing when nurses want to take extended time off. I remember, and also what nurses have to go through to get a day off is pretty industrial age, and I'll admit that because I was a part of that too, where you have to submit paperwork. It has to go through a couple of different desks and hands for approval. It takes sometimes 6 days to weeks to know whether you'll be approved. There's this process typically around prime time, which is the major holidays. If you think about how people in other industries manage taking a day off compared to how it's managed in healthcare, is very, very different. And you have this new generation also that's coming out and saying, I don't have to deal with that. I should not have to be on pins and needles to ask for a day here and there, or even being put in a position when you do unexpectedly want to ask for a day off for a schedule that's put out 6 weeks in advance, and you have a situation where you have to do some maybe support your mom taking her to a doctor's appointment, and the person that's managing the schedule will say, well, go find somebody that will switch with you, right? And
Yes, I
so
heard that one.
you
That's a
don't
good one.
so that's the other thing, the culture that we need to change, because we don't make it easy for people to request time off. And it really is setting up people to say, like, how do I know what days I'm gonna need six off for 6 weeks from now? Like, I don't know. But that's the way our systems are set up. The schedule goes up for 6 weeks, and you have to hold to it. And for you to want to make a change, it takes God, country, and unnecessary bartering for you to get a day off. And that is not.
Okay.
That's part of the culture that we have to break.
That's another great point. Okay, Amy, I want you to chime in on this, and I've got guys who put in comments. I just see your comments. I'm going to read those off. Those questions. You guys are great questions. Thank you for that. I'm going to read them in just a second. Go ahead, Amy.
Yeah, no, I agree. I think, and I struggle with that too when we have certain numbers of caregivers that we allow off.
Yeah.
And they'll say, how come we can only have one person off? And it goes back to the original thing that we started with is it's the double-edged sword of having enough staff to care for our patients but allowing them enough time off. And
Mm.
it's a really hard place to be in. And then if you're running a business, and I mean, part of it is we have to be mindful of the business. Then if I have too many people who don't want the time off, then what do I do with them? And so, some people say, well, just pay them. It's like, well, I mean, the payroll only goes so deep. So that it's a very fine line of you have to allow time for them to be off. And I agree with you, Katie. I think the trick that we have to solve is how to get more creative.
Yeah.
And I think that's with more creative scheduling, to your point, by allowing people. I mean, people don't want to work as much. And so if you can give them a month off and maybe you hire two people and they split the year or something like that, I think it's going to have to be that we're going to have to really get creative.
Yeah. I mean, I was seeing signs from my environmental scans where leading it was probably October, and there'll be managers that will post signs at the nurses station, and nurses will take pictures of them and post them on social media. No time off is allowed this holiday, or you only get 1 day between Thanksgiving and New Year's. Or another one that I saw was and again, it was probably fall of 2020. Make sure you put all your requests in for January through March of 2023. And if we don't get them by the end of November, you can't get the time off that you want. I mean, those are the types of things that are unappealing to nurses, and again, also to the new generation, because a lot of us have just waged to navigated through that and said, well, this is the way it is, so we'll just deal with it. But there's a generation now that's saying absolutely not. And the folks that have been dealing with this and managing it that way for this long, and also saying, yeah, actually you're right, it doesn't have to be that way. I want some creativity too. So yeah,
Mm.
that's where we
Hmm.
all have to. And I always talk about the millennial effect and the Gen Z effect, the Gen Zers and the Gen Zer effect, right? The millennial and the millennial effect. What these folks, new folks, these new breed of nurses are wanting, folks that have been in nursing for a while saying, well, you know what? I think I want that too.
Yeah,
You want what? Say it again.
they want it too.
They want it too.
I want it
They're
too. Yeah, yeah, yeah,
done
yeah.
with the old way, and they want to see how we can do things a lot differently than we have before, particularly as it relates to time off, vacations, and things like that.
Okay, so I'm gonna definitely read comments. We got a lot of comments I got to read. Okay, but I want to just think about something for a second. The hospitals have actually been doing it. They've been doing all the stuff that nurses have been asking for. They've just been paying the nursing agencies to do it for them, right? Because the hospitals are paying the bills, or unless the state helps. But they've been paying the bills. But it's just that they haven't been doing it directly for them. The nurses have found a way to do it through the agency, so they're getting kind of what they want through the agency. So in a sense, even though there's a middleman there, they actually have been doing it. I'll let that marinate for a second. Okay, let me
Yeah,
read the comments.
yeah. At a high cost, though. At a high
At a very
cost.
high cost, very high cost.
And
Yes.
a very
Okay.
fraction of the total number of employees.
Yeah.
Like if I
That
only have
yes.
200 agency and I employ 2,300,
Yeah.
it's a fraction of the people.
That's true. Okay. So here's Brian says technology and alternative care sites have created more opportunities away from the bedside. Okay. Well, I think we're gonna probably have to table that one and come back because he's right. But let's come back to
Yeah,
that one. That's a
absolutely.
good one.
Mhm.
Okay. Dr. Chad Key, he says ENA has a good calculation methodology for ED borders and throughput for clinical resources. That's actually some of that. I'm assuming he's talking about emergency nursing.
Yeah, probably. Yeah, Emergency Nurses Association. Yeah.
Okay. So is he saying that maybe these are things that we should be putting across the board, not just for ER, not just for the ER, but across the whole organization? You think that's what he's kind of getting to?
Well, I'll let Amy take that one because I do think there are a lot of best practices and strategies that are out there, but it also to execute them, you need the bodies, you need the people, you need the talent, right? So
Right.
without that, you're nowhere.
And
Mm.
to his point, there are a lot of things that you can do to minimize the number
Yeah.
of borders, or we call them EDIs. Then there's also a best practices, which we've done a lot to improve safety and to improve throughput.
Hmm.
Okay. And then Ellen Nasberg. By the way, he says yes. That's what he's thinking. He's thinking maybe use the ED throughput for the whole organization. Okay. Ellen says, has it been possible to attract nurses who have semi-retired or left direct nursing to come back to nursing, even part-time or with very flexible or individual schedules? What are your thoughts on that?
So I've been able to bring some people back, but they are very specific about what they want to do. So we've used them to teach our BLS classes. We've used them in our employee health area, to make phone calls to our own caregivers that have COVID. So we have tried to utilize them, but most of them, from my what I see, is that they do not want to go back to the bedside, and to take a patient care assignment.
Mm,
Yeah,
okay.
I'm hearing the same thing, Amy. Even though it's a good idea on paper, but a lot of there when a lot of organizations with I think it was the Affordable Care Act years ago, where we all had to implement EHRs, and put those documentation systems in place as a standard. There are a number of our nurses, and I recall this vividly because I saw it, where there were some nurses that were very close to retiring that said, "You know what? I don't think I care to learn how to document online. Like I prefer my pen and paper. So if I'm going to go through this, I think I might as well cut out and leave, right?" So for a lot of these folks that left during that time, just think about bringing them back in to still have to learn that documentation system that they didn't want to engage in when those were implemented, and that's a challenge. And for any nurse, the when you walk away from the particularly in acute care and some of these specialty areas, it's a tall task to have them come back and perform at the level that they used to when they were on staff. It's a documentation system. It's the protocols. It's the required competencies that they have to take. It is not a turnkey solution in a lot of
No, trust me,
cases.
Mm.
because I've put my scrubs on and come back, and I'm really good at toileting people, and doing some of those things. But if you ask me to take a whole patient care assignment, I'm a little rusty.
Yeah.
That's a good point. Okay, so let me ask you this then. Out of the things that we've discussed so far, if we were to, oh, Jane says, not hearing resolutions. This is a session to kick around issues. Okay, well, I don't know. We just we let the conversation take us where it takes us, right? Because I think it's good to kind of get some of these things out, because what you guys are talking about are the same things that all these other thousands of hospitals are facing right now. So I appreciate what we've done so
Yeah, and
far.
I can speak to that though, because what we have done at at ANA is we've assembled a group of not just nurses, but nurses at the front line, all the way up to CEOs, and we've assembled a think tank to work
Oh,
and the
okay.
moonshot for this group. And we've started meeting in January, and the charge is to meet 6 times over 3 months. And by the end of those 6 meetings, um, we all develop some short-term solutions. And I mean solutions that can be implemented in 12 to 18 months to make a difference with what nurse leaders are dealing with right now. And it is a challenge to do that because a lot of the issues that exist are multifactorial and complex. But the group that we've assembled are really energized to do this. So I know I'm kind of putting it out there, and that means I have to cash a check that my mouth is writing the check for, to make sure that we have these solutions that I'm putting out there we're going to do. But I think the team is going to do it. And we started with listing what the top challenges are, prioritizing them based on a multi voting system, Now we're going to work with the group on developing strategies that could be implemented. And again, it's short term to take some of the pressure off at least. So I look forward to sharing that at some point, but it'll be in March that we'll hopefully have something to show for it.
That's great. That's fantastic. Let me just see what some of the other folks think about it. They love it too. So that would be wonderful.
And Katie, it's interesting. As soon as you said that, I just did a think tank with our frontline caregivers about staffing. I just put a staffing think tank, and it
Yeah.
was 2 hours, and they all came with their lists. They were kind of spokespeople for their units, and so they had some really creative ideas that we are working. Um, we are a union organization, so it does take a little bit of coordination of our efforts, but
Sure.
we're working together, and they have some great ideas that we're going to implement. The other thing that I've been doing now more than ever is working with my academic partners. So the community nursing schools, community colleges, and the university. We have a university close by with MSU and Davenport, and they have some. Also, they've offered some really creative solutions to
Hmm.
staffing and just even onboarding people here quicker, so that they
Yeah.
could start in a different role while they're in nursing school. So I do think that it's caused us to think differently. And
Hmm.
while some people have suggestions, and maybe Katie and I are saying, no, I don't think that'll work. There, what I always encourage people is keep saying your suggestions, because I think that there's
Yeah.
little pieces of them that will help us.
Yes.
Absolutely.
And
Absolutely.
maybe a future iteration could involve some of the suggestions, but maybe it's tweaked enough where it can work.
Yep.
So yeah, I love it. So thank you, Jane, for mentioning that. And Dr. Chad Key, he came back and said not the whole hospital, just ED and med surge interventions. He's talking about for that throughput thing he was
Okay.
talking about. Okay. And then Marla, hey Marla, good to see you. She says specialty nurses are leaving because they are asked to float to areas they are not comfortable with working in, such as OR nurses being asked to work the floor or PACU nurses asked to work ICU. This is something they can refuse up front prior to accepting a travel contract. We need to ensure that nurses asked to float have the competencies in place and feel safe. I've not heard of many nurses demanded to float by CEOs and have tried to use safe harbor only to have the hospital deny the request. These nurses have left the nursing profession.
So I can
Thoughts on
speak
that?
to that. I
Okay.
know that some nurses are very comfortable and confident and competent because they go to the OR, but they were previously on a med surge floor. So we really try to meet with every nurse and ask them and really do an evaluation of their competency. If they weren't competent, they went to another unit as a helper nurse. And so they were not given an assignment. They were there to really be to help pass food trays or to help with the restocking of our PPE. It was really something that if we would have not floated them, I think what we would have found on the other side of the coin was those nurses that were doing the work would have felt a little bit abandoned because we would have sent them home. And so it was important to us to make them feel safe in going to a unit that they're not very familiar with, and making them feel safe, but then also giving the people that were working on the COVID floors that assistance that they so desperately needed.
Yeah.
That's a good point. Okay, so Brian says thank you for that. Brian says great comments by Katie. My son-in-law is a travel nurse who stated that this is a once in a lifetime opportunity to travel and pay off debts and invest in their future. Also, many nurses are becoming empty nesters and now have the ability to travel for much higher pay, often closer to home due to the compact changes. I guess compact. I think so much compact
Yeah.
state.
Yeah. I'm hearing a lot of familiar names there. By the way, is that Brian Hudson?
Brian Hudson, yes.
Yeah. Hi, Brian. And I heard Chad and Ellen, so I'm hearing some familiar names there. Uh, but it's this is what's also different, right? It's you can also travel locally. You can sign up with a travel agency and stay home and not have to get on a plane to go anywhere. You can actually work at a hospital 20 minutes from you today, sign up with a travel agency, and they'll put you back in that same hospital where you're working alongside someone where you used to work with that, and you used to earn the same pay with, but now you're there as a traveler making more. So the options are wide open for travel nursing at this point. So it is all of those issues, Brian, that you mentioned, in addition to the fact that it's a lot easier and desirable to enter into that type of employment because it offers you a salary that's nowhere in comparison to what you get working at a hospital. And there are things that we need to do in hospitals to make nurses want to come back and be a part of those teams.
Yeah. Okay, here's another one. Now, I don't think we have time to touch it, but I want to hear what y'all, if you have something you want to say on this. This is a great comment from Leanne Van Laer. Welcome. That's the first time I've ever seen her come across. Welcome to the show. She says long-term care nurses are leaving because the staff to patient ratio is 40 to 80 patients. Many of them know they're going to be required to do the job of multiple nurses prior to entering the facility. My question is this: if the facility and the staff that their building requires 2 to 3 nurses to a unit, shouldn't them not having to pay those other 2 nurses allow them to pay the one nurse that is doing the job of 2 to 3 nurses? Did I read that too fast, or does that make
So
sense?
no, I can touch on that because I actually had this question come up with my staff. So I think they're feeling like because we don't have the number of nurses, like we have 200 open positions, then shouldn't, like to her point, if we require six and we only have three, shouldn't we be able to pay those three nurses more because we're missing three nurses? The problem is that we're paying three times the amount to our agency nurses. So if we have over 200 agency nurses, and honestly, we just gave our nurses a 6.25% increase in their pay, a pretty large retention bonus, and so I mean I do think that they're compensated very well, and they have very low costs for benefits, um, but we still are not paying them $200 an hour. And the other thing is that agencies are making more than the actual nurse. So the hospital
Mm,
organization might be paying 225 an hour. The agency nurse is taking, 150 or whatever. But you can't make up the difference in that if you're paying three times the amount.
got it. Okay. Also, one other question, because I know we're out of time. Dr. Chad Key says, what are their recommendations to leverage APPs and keeping practitioners operating at top of license? Also, how can telemedicine be advanced into nursing practice?
Yeah, those are great questions, and we do see it's a nice for APRNs. There are opportunities galore. Now, of course, there are issues with onboarding, and APRNs that are new to practice to make sure that they move through the Benner stages effectively versus baptism by fire, because that's what we're seeing a lot for our APRN. So that's an opportunity with mentorship being one avenue to help with onboarding, I think will help. The other thing is because part of what we have to do in nursing is to come up with new care delivery models. We can set up care delivery models where APRNs are the leads of teams, and they're working closely with a team of RNs, LPNs, because we're seeing LPNs in acute care now, which is I say is a good thing, and CNAs or PCTs to make sure that we are providing care appropriately, holistically, and also make sure that and also that it's safe. Because I do think there's room for APRNs outside of critical care, because we have APRNs in critical care mostly and in the NICU. But I think there are models that should be explored where APRNs are also in med surge and some of those other areas, so they're leading teams.
Mm-hmm.
And I think that would help with particularly APRNs that have a desire to stay in the acute care setting, because there are a number of them that are being pushed in the ambulatory setting, which is unfamiliar territory. Or there's a way to do both, right? Because You're building new hospitals should be built from the outside in, right? You build the ancillary services around where most of the care should be delivered, and then the hospital becomes where the emergency needs are versus emergency rooms being used as doctors' offices. So I do think there's an
Mm.
opportunity to leverage those talents, particularly with nurses that are going through family practitioner programs. There are a lot of them, and keep them home, because the worst thing for me, I remember as a CNO, I would lose some really, really amazing nurses that only because they went through an MP program and I didn't have any
Oh
physicians
yes.
for them, and then they're gone, and they're working in ambulatory care, and I'm thinking all that wisdom and talent and competence is gone. When is my next nurse going to come from that can mimic or mirror that talent that I lost? So
Yeah.
I think that's part of the strategy that should be implemented, is to keep them home when they finish their programs and have them practicing at the top of their license. Absolutely.
Yeah, absolutely. Well, I tell you, this is I love this discussion today, y'all. This is a fantastic discussion. Um, Sorry, Dr. Curtis couldn't make it. I'm sure he'll try and catch one of our other ones, but I'm so glad I had the two of you. I tell you, it was great. So we didn't solve all the world's problems in an hour, but we definitely covered quite a few things I think that are definitely appropriate and kicking around some ideas. This could only help going forward. So thank you both for being on today.
Thanks
Thank
for having
you.
me.
Absolutely. One of my future shows I'm thinking about as we're talking through this, just like the physicians supervise a lot of nurses. I'm sorry, a lot of NPs and PAs, like the supervising model. As you were talking, Katie, you're making me thinking. I wonder if one day maybe the APRNs would be a supervisory model over several nurses, or perhaps even nurses being supervisory model over several CNAs, to maybe extend the reach of some of these nurses, to maybe expand the nurse staffing ratios. I don't know. It's just
Yeah. Well,
crazy
it
thought.
is, and that's the thing. We need to break the impression that for nurse practitioners to be able to practice effectively, they have to be under the thumb of a physician. A lot of them are worth their own salt and they can do their own things. We have a number of very successful nurse led clinics that are completely 100% nurse led. But we want full practice authority in every state for that to happen. And then,
Mm,
Rollins, we'll be able to see what these nurses can do, because they're absolutely capable of leading teams,
wow,
and not
awesome. Well,
and not require having a physician sign off on their work.
got it. Okay, well, my I'm happy. My audience is happy. I'm just checking in. They loved it. It was a great session today. Everybody loved it. So thank you for being on again today. You guys are amazing. Hope you guys can come back on the show again soon. Let's say bye, everyone. Bye, everyone.
Bye.
Okay, and then Joanne's gonna let me know. Actually, no, Joanne's gonna do it. Joanne, you're gonna go ahead and do it, and then you let me know whenever you cut off the stream. But as she's doing that, we've got Carol Ann Giola, Dr. Giola. Appreciate you. Yeah, she says thank you. Florence says agree. Leanne says thank you. Benjamin says very informative. Thank you. Everyone's loving it. Everyone loved the session today. So thank you very much. Everyone's comments
Great
today.
questions. Great
Yeah,
questions.
those were
Yeah.
excellent questions.